Welcome to the AIMI Grand Rounds. This is episode 2. It's a monthly series hosted by the Stanford Center for Artificial Intelligence in Medicine and Imaging and takes place on the fourth Tuesday of every month. And our goal is to feature AI research being conducted in clinical environments and just raise the awareness of what can AI do amongst clinicians. And we'll talk about the cutting edge applications, as well as today we'll talk about how we govern those cutting edge applications. And we'll be featuring interdisciplinary lectures from medicine, engineering, and other fields. The goal is to create a community where people who are developing new methods can interact with the users, can interact with those whose job it is to evaluate these things and deploy them in the healthcare system. For claiming CME credit in the chat, there's details on the text code you need, and you'll also receive instructions after the session via email. Q&A, use the Q&A function, and the AIMI Center staff will help me prioritize the questions. Like once we're in presentation mode, I don't see the chat directly. So please use the Q&A function. And the full schedule for the grand rounds will be posted on the AIMI website soon, and you'll find the link in the chat as well. I see it just got put in there. And then a couple of other things. There is a Health AI Week happening on our campus in June, starting June 2nd, Monday, with our Raise Health Symposium. And then the next 2 days are AIMI related, with the AIMI Symposium on Tuesday and the AIMI Pediatric Symposium on Wednesday. Then we'll round out the week with a CHAI Symposium and Health AI or HAI Policy Workshop. So just save the date for now. Details will be coming soon. And I think we're at 9:02 and looks like everybody's in. So let's get started. So I'm going to be presenting, well, I have a slide on screen, but it'll be mostly a slideless talk. So let's see how this goes. It is an experiment. I typically do this in a live setting, but we'll see how we can port it to a webinar format. So I want to start with sharing my two roles. One of them is data scientist. The other is professor of medicine at the university. The reason I bring that up is it gives a nice balance between doing research about AI in medicine and then the concerns that come up when we're supposed to deploy those things, scale them, maintain them in the healthcare system. So it's a fun split. Sometimes it feels schizophrenic, but by and large, it's a lot of fun. So what we're going to talk about today is the things that I have learned firsthand while serving in these two roles over the past 2.5 years or so. So that's our agenda, and this is mostly a cheat sheet so that I know what are the topics we want to talk about. We'll probably spend about 3 to 4 minutes on every topic. I'll be using a virtual blackboard to draw in lieu of slides. And I will also be asking all of you to imagine a few things. And if you have pen and paper in front of you, it's good to have them out so you can follow along, draw and scribble notes or what have you. All right, so let's get started. So the first thing that I find worth discussing, and perhaps the most important point in doing AI responsibly, is to think of the patient data in the form of a timeline. So imagine an arrow of time going left to right on the screen. And if you have paper with you, please follow along. And on that, let's imagine certain medical events that are happening. I'm going to just put down a few circles. And these could be things like, getting the flu, going skiing, getting a leg injury, getting COVID, getting your routine colonoscopy, whatever it might be. So let's say these dots are events that happened. And you could imagine your timeline, you could imagine a loved one, somebody you know about if you're a clinician, and you can imagine a patient that you just recently saw. And these visits can span multiple specialties. Each dot could be a different specialty. There is supposed to be a primary care provider who knows everything that is going on, but it doesn't always work that way. And then what I want you to imagine is and I'm going to change color just so that it's clear. The data that get collected underneath each visit. So, we love collecting ICD and CPT codes because that's the way we get paid. We write prescriptions, we order tests, we write notes, we might measure EKGs, and it goes on and on. And if we sort of put our heads together, there's about 122 people on the call. Um, we could end up with about 200 things we like to measure. Um, every hole in the body, we can send a camera up and take a picture or a video. We can do histopathology sections. We can measure electrical signals from the heart, the brain, the muscles, inside the esophagus, and whatnot. I mean, there's a lot of different modalities that we collect across the multiple specialties. Stanford, for example, has 123 residency and fellowship programs that are ACGME accredited. 123. And each specialty probably has its 5 favorite tests they do. That's like already gives us about 600 items that we measure. Now, two things remain true. At every visit, we're not going to collect everything. So, we might have a few things here. At another visit, we might have a few more things. Some visit, we might just have a prescription or a test. We might have some imaging studies, and so on. And so this construct, let's call it the patient timeline object. There's two things that remain true about it. Thing number one is there is no point in time, and let's just pick this point in time, where we have collected everything. That makes sense. I mean, we don't really do all possible tests when somebody shows up in the clinic. We don't do an ultrasound and an X-ray and a CT scan at the same time for a person. We only collect what's needed. And then the second thing that's true is if you look at any modality, nobody has a longitudinal record over 5 years, not even the patient. So this is really important. Like before we even begin AI, we have to have a conceptualization of what are the data using which we're going to be doing said AI. And this thing, let's call it, give it a name. I like to call it the patient timeline object. And we have this patient timeline for millions of people. I've done research with this patient timeline for about 200 million timelines. Now, of course, they're not fully populated. You don't have all 500 modalities at every time point for everybody. These two limitations remain. But it's important to pay attention to this because people in specific specialties love talking about the 5 or 6 modalities they care about. But from the patient standpoint, it's everything. It's the same person you're poking, scanning, taking a biopsy out of. And so I find it really useful to think in the manner and from the point of view of a patient. The other thing that's useful about this is that these data are spread out across multiple IT systems. We like saying the shorthand EHR, but there is electronic health information scattered across, in case of Stanford, about 1,300 IT systems. I mean, not all of them have patient data in them. Let's say, probably 300 IT systems in which there's patient data. The EHR, such as Epic or Cerner, being one of them. So that's also something important to know, that where are parts of this patient timeline residing? Because you will have to go dig in those IT systems to extract the data and then link it all up so we have this patient timeline. Okay? So really core concept. Now we take this patient timeline and we build models. That's the second big thing. We're not going to talk about the models. Kurt gave you a very nice overview last time about multimodal models and so on. So let's say you know all of that. We know how to build a model. We're going to focus on what do we do with those models. So here's my model. Just going to write it down. And the model could be a logistic regression, could be a deep neural network, doesn't matter. What I will submit to you is that a model does two things and two things only in healthcare. It helps us decide whether to treat and how to treat. So whether to treat is basically risk stratification and can be further decomposed into classification or prediction. And I make a distinction between these two because in general speaking, we say things like, I have a model that is predicting the patient has sepsis. There's no such thing as a prediction of sepsis. What the model does is the patient has sepsis. We've not yet figured it out. It's a classification exercise. Just like you might say, here's an image and I predict there's a dog. It's not really a prediction, it's a classification. I mean, the thing was a dog before we even took the picture. And so it's important to maintain that distinction because classification is diagnosis. We're diagnosing sepsis by using a model. Prediction is prognosis, where you say, what is the chance the person lives or dies? Different ballgame. The how to treat is the hardest because we're making treatment recommendations and that we require counterfactual inference to be done, lots of math developed around observational studies and how to do them right. I'm a huge fan of the observational health data science and informatics community called Odyssey. So we have these three things we can do with models. Now we can do these three things, and I'm going to just erase this real quick and go here and say we have classify, predict, and then make recommendations or treatment recommendations. Now we can do these things for the purpose of advancing the science of medicine, the practice of medicine, or the delivery of medicine. Sometimes I call it the business of medicine or healthcare. And this is really important because where we land in this 3x3 grid is super important in deciding how we approach things and what challenges we will face. So just as a quick way of giving an example, there's a nice group of researchers at the University of Northwestern, one of whom, Dan Katz, is now at our department in medicine at Beamer, who analyzed data of patients with heart failure with preserved ejection fraction. It's a weird thing. We say you have heart failure, you have symptoms of heart failure, but ejection fraction is fine. And found that that particular condition has three subtypes. So subtype 1, 2, 3. If you're subtype 1, let's say you're dead in 2 years, subtype 3, you're fine for a decade. It's a classification exercise. Their classifier, when applied to new patients, sorts them into subtypes 1, 2, and 3, and it does match the prognosis of their patients. So now it's telling us that based on these data, we know that this thing is heterogeneous. And this happens in medicine all the time. Diabetes used to be one disease, and now we have type 1 and type 2 and so on. So let's say heart failure with preserved ejection fraction is three things. Practice would advance if two more things happen. I have a test, which is an algorithm, could be an imaging test, could be a blood test, could be measuring gene expression. I don't really care what the test is. I want to spend $2. New patient walks in and categorize them or classify them or diagnose them into subtypes 1, 2, and 3. But along with that, I also need a treatment. Because for the ones that are at high risk, I need to be able to do something more. And for those that are at low risk, I need to be able to say, like, you're fine, let's not do anything to you. Until we have that change in practice and we have the treatments, clinical practice is not going to change until we have those guidelines and those treatments. Now, let's say we had that too. Delivery would change if we do this test and train regime for 5,000 people for 5 years and they live longer, they have better outcomes, or they cost less, or both. And so as we think about applications for AI, it's really important to figure out, are we in the science column, practice column, or delivery column? Because the pressures under which we operate are different, and the way we're responsible is also different. On the science side, like the goal is to, publish in Nature Science Cell, and you have very different ways by which you accomplish that. The practice side, you want to show benefit to patients, and if you're successful, you go to JAMA, Lancet, New England Journal. And the delivery side, you may or may not publish. All you see is change in your patient satisfaction scores, or in your value-based contracts, you're doing better. And so it's really important to figure out where in this grid you're trying to play. All right, so let's look at two examples here. So example one is here, and example two is going to be here. So the first example is where we launched a bedside service at Stanford. We call it the Informatics Consult Service. Where given a question that is triggered by a specific case, within a day, we produce a report of what happened to similar patients. And we produce that report from about 200 million patients worth of data. We did 150 cases. The first 100, we wrote it up in a New England Journal of a Catalyst paper. And it was the first time in 40, 50 years that this idea of answering a question based on what happened to patients like mine was done at scale as a operational service. We call it the green button service. Lots of support from our dean's office, the National Library of Medicine, the Emerson Collective, and so on. And when we were done, our leaders asked, how are we going to scale this? And so you can't have an academic lab trying to offer this with 3 students to, multiple hospitals. So we spun out a company. So that's here. And it's the Green Button project. And greenbutton.stanford.edu URL still works. My handwriting is terrible here. Let's look at the second one now. Here. So we built a predictor for mortality. We started down this path in about 2017. We spoke with every tech company that was willing to do a machine learning in healthcare, and none of them wanted to do anything with it, saying AI or ML and mortality in one sentence, too risky, we're not going to touch it. So we had to do everything on our own. So we built a predictor for anticipating the risk of mortality in the next 9 to 12 months. That was the easy part. We built 3 models, wrote a bunch of papers about it. The hard part was doing something. Our workflow for doing advanced care planning at that time had 21 steps, 7 handoffs between people belonging to 3 different service lines. We could only do 4 to 5 per day. And so I might have the world's best model to make that prediction, but if the follow-up action doesn't happen, nobody gets better care. And so we teamed up with our palliative care division and Dr. Vinny Tudberg and Serious Illness Conversation Program, and lots of people got involved to create this training material and then subsequently workforce capacity that if somebody got flagged, we know we have somebody who can have a conversation with them about their goals of care and complete advanced care planning. Took us 3, 4, 5 years end to end, but at the end of the day, we're now able to flag patients, and within a span of a few days, somebody has a conversation with them about their goals of care. About 6,700 patients have received this kind of conversation. And the most important thing is that the number of actions carried out by physicians is now flatlining, but the total number of actions happening is still going up, meaning we've built up capacity and we're not just gated by physician time. Residents, nurses, medical students, spiritual care workers, respiratory therapists all pitch in for this to happen. So the point of sharing that story is that a model or a prediction writ large has value if and only if we can do something about it. Same thing for the classification. It has value if and only if we can do something about it. So in this delivery column, which is the last column, good AI happens because of an interplay between models, the policy and work capacity. And policy here, I'm not talking federal policy. I'm talking, what is the threshold at which you're going to do something? That kind of policy, local policy. And then capacity is about how much work are you able to do in case of that example we're looking at, how many advanced care planning conversations we can have. And then finally is the trade-off, the risks and harms of the action we're going to take. So this interplay here is where good AI happens. We have to study all three. I'll give you another extreme example. There's a company called VizAI, I'm not involved with them, that can analyze a CT scan or an MRI and identify a CT scan and identify whether someone's stroke is hemorrhagic or ischemic. And if you happen to be in Central California and it's a hemorrhagic stroke, there's a policy that says you should be put on an air ambulance, a helicopter, and transferred to UC Davis. Somebody will drill a hole and get the blood out, and you have better outcomes. So the action is to drill a hole and get the blood out. Policy is you get the air ambulance. The model tells you whether it's a hemorrhagic stroke. But the key point is all of this works if and only if we have the air ambulance. If 5 people have that problem and we only got 1 helicopter, it's not going to work. Now, it's an extreme example, I grant you that, but the point is that work capacity matters a whole lot more than the quality of the model. And the reason I bring this up is if you look at the guidance being given in published literature, about half of the guidance, 50% of the guidance, is how thou shalt build a good model. Very little on the capacity issue. When we did the original review on this, Jonathan Liu, who's now a resident, did that work. There was nothing, like 0 recommendations on how you should do capacity analysis. And so that inspired us to build something that analyzes all aspects, the model, the policy and capacity in action. And when we look at the action, we also want to look at the financial sustainability. Can we keep doing it year over year, day in, day out? And so that led us to creation of something we call FIRM, Fair, Useful, Reliable Models. firm.stanford.edu is the URL for that. And it's a process, multi-step, goes in 3 stages. And in stage 1, we basically ask questions related to these 3 things. What does your model do? What do you do in response? What is the workflow? What's your capacity? We can even do a little simulation to make sure there are no bottlenecks in your capacity. We look at the sustainability of the action, and we also look at the ethics of the interplay. Because sometimes we might think that using a model to predict something and take a responsive action is the brightest idea, but then we ask other stakeholders like patients, nurses, physicians, and they might say, well, I don't think so. And then that opens a conversation about what is the real matter there. And so FIRM looks at all 3 things, the model plus workflow, the ethics, and 3, the policy and capacity. And capacity, we look at sustainability in the same bucket. We've been doing this since late 2022, and we had all of this figured out. We did our first tranche reported in the paper of about 8 FIRM assessments. Now we're doing them at a clip of about 2 per month. And we're feeling pretty good about ourselves that we are really being responsible. And this FIRM assessment itself is embedded into a larger thing, which we call our responsible AI life cycle. Unfortunately, there's no public-facing material about this. It's an internal business process about how do you invoke form assessments? What is the governance process in the terms of who reads the report of that and makes a decision to go or no go? So it's basically our internal dance of, as an organization, how are we going to do this? And our CEO and our David Entwistle and CMIO Topher Sharp co-chair the committee that oversees this responsible AI lifecycle. So we're feeling pretty good. Like we had this all figured out. And then large language models happened. Um, and so that kind of put us back to a little bit to square one, because LLMs are weird in the sense that they don't really have a probabilistic number that's being given out. The workflow in which they're used is unclear. The ethics part we can still assess. Is the situation acceptable, the use case acceptable? But we had to do a lot of other thinking. And before sort of we dive into that, I want to talk a little bit about this whole notion of language models and how we would benefit by thinking about them a little bit differently. Okay, so here goes. We had that patient timeline with a whole bunch of these dots, and then different things get collected along the way: ICD, CPT, RX norm, maybe an image, and what have you. Now, as these things are arrayed over time, from a computer standpoint, it is a language. And it is not a natural language. It is not like English words, Spanish, German, or what have you. And the inductive biases in it are different. So in natural language, when I say, where are we? And then the next word is at, or, on my, and immediately way. And the way these things are trained is you're looking at massive amounts of textual content and learning probabilities of the next token, roughly speaking. Of course, there's masking and other kinds of things, but very roughly speaking, that's the intuition. Now, in case of medicine, the inductive bias we need is slightly different. When I see someone's portion of a record, maybe I'm interested in what's the next token, but often what I'm interested in is how many days will pass until I see a certain kind of token, meaning how many years till a heart attack. And so, given that this inductive bias is different, that gives us two ways to build language models in healthcare. One is the classic way where we're thinking of documents and we feed them into these regular LLMs where language means natural language. And then the other is where we feed timelines. And these timelines give us these embedding models that don't talk to you, but they give us some other interesting properties, such as the ability to forecast what is going to happen. And we'll come back to that. So for now, remember these two things. We have these traditional models or language models, I shouldn't call them traditional, LLMs. And we have this new way of training things. And let's just, for our argument's sake, call them timeline models. So here we are. These things have come around. We've been studying these timeline models since 2021, but then LLMs hit the market and everybody's super excited. We have that form assessment thing going, and then we're like, okay, what is our strategy? What are we going to do? So the thing we came up with is that we do have to verify presumed benefits. That's sort of the key concept that I want to share with you. So instead of recycling that triangle, we're going to now say, here's our model. Change color. Here's our model. Then we have some strategy to verify presumed benefits, and I'm underlying presumed. And then we also have to figure out how are we going to deploy in a healthcare system. And then this interplay is what we need to study. So we said, all right, let's look at presumed benefits. So, people were trying to use these things for clinical decision support. And remember, I told you about that bedside service where we had a whole bunch of questions that we had answered. So we took a few of those questions, about 60 questions, and submitted them to, at that time, GPT 3.5, and then very soon GPT 4. And then we showed the answers to 12 clinicians and asked those clinicians to opine whether the answer agreed with the previously known answer, it disagreed, or they couldn't tell. Okay, simple thing. Well, from GPT 3.5 to 4, agreement went up, disagreement went down, could not tell went down. So great news from a technology development standpoint. The headline is in that both of those settings, about half the time, the 12 physicians did not have a majority about what was the case. Is it agreeing, disagreeing, or it's too confusing? Half the time. So the point being, answering USMLE questions doesn't really help bedside decision support. So presumed benefit didn't pan out. Experiment number 2. We started giving prompts such as summarize this patient's record for their previous strokes and the neurological deficits they had. And we give the prompt, we give the medical record, the LLM produces a response. We also ask the physician to produce a response. And we did that on a project called MedAlign. And now we release the data publicly as well for you to verify what I'm saying. Even in the best case setting, at that time when we did the experiment, it was 2023, late 23, 35% error rate. 35%. Just think about that. Like, we're using these things to do tasks, and we have never verified whether the presumed benefit will materialize. I'll give you one last example. You've all heard about using language models to respond to in-basket messages and so on. Everybody, including Stanford, went in saying this is going to save us time. There's not one entity that saved time. In fact, UC San Diego reports 22% increase in time used by the physician. So presumed benefit did not pan out. Fortunately, in that case, when we measured cognitive burden on physicians, cognitive burden went down. So we accidentally discovered an additional value proposition that made it all worthwhile, but it could have turned out not that good. So again, we need to focus on verifying presumed benefits. So then if we go back to these timeline trained models, these things here, what might their presumed benefits be, and how could we verify them? So I told you they're better at forecasting. They're also better at classification. So one of the things that we did in that case is we made a plot like this. So on the x-axis here is number of samples you learned from, let's say 1 to all the data. And then the y-axis performance, let's just say AU out of C for now. And then we created plots that say, if I'm learning from just one positive example to train my classifier, what's my AU out of C? And if I learn from 2, 4, 8, 64, keep going, okay? So we got a plot like this. And then we made a similar plot for classical methods that went something like this. Actually, let me redraw this one. Okay, here's our grid. This is the data 2 to all, and then this is the performance AU out of C. And let's first draw the regular performance. So it went something like this. And then for the timeline trained models, it went something like this. And so the point was at here, this would be about 128 samples. So at 128 samples, the timeline trained model would learn a classifier as good as what you would have learned from all the data using standard methods. This is huge. Now I can train a classifier for rare conditions. I only need a few positive examples to get performance as good as I would have gotten training with all the data using classical methods. Amazing. Okay. It's not going to make a New York Times headline because it's too geeky for that. But we partnered up with the Chan Zuckerberg Institute to see if we can use this technology to build classifiers for rare diseases, things that we routinely miss. Again, these are diagnostic engines, not predictors, but patient has the condition, we haven't figured it out. So in that sense, they're like sepsis, but we don't have that many training examples. So using very few examples, using these timeline trained models, we can train such classifiers. So that's about verifying the presumed benefits. All right. Last couple of topics, particularly in case of large language models and Gen AI writ large. There's this notion of having human in the loop. Not a huge fan of that. And the reason I say that is that human in the loop is a cop out just to shirk responsibility and put the burden back on the human. Um, in fact, there's articles out there by Julie Adler-Milstein and Bob Wachter from UCSF talking about how unreasonable that is, that if the AI is truly doing something the human is not able to do, why do we think the human can verify its output? Like this just doesn't compute for me. Here's a concrete example. When I trained in medicine to do the CBC, the differential blood count, we would look through a microscope and count, like manually, how many white blood cells I'm seeing and of what kind. Today, we do it with a machine. It meets every definition of AI. We put blood in, an algorithm runs, a laser shines, an algorithm runs, and it does the job in the stead of a human being, and out comes a CBC. Now, if we required a human in the loop, saying the pathologist has to verify that the machine CBC output, how useful would that be? So, like human in the loop, I think is a little bit of a fallacy. It's because we don't know how to evaluate AI. We just sort of raise our hand and say, human in the loop, don't bug me, bug the doctor. But last I checked, we wanted to use AI to help the physician. So why would we increase their work by asking them to check more stuff? So human in the loop, be careful. And then, so that's the topic. I'm just gonna write it down here so that so that was human in the loop. I'm a huge fan of human not in the loop. Like, let's go back to pathology. Everyone's trying to build a digital pathologist that would put a pathologist out of business and do my job instead, and do the job in diagnosing what is being seen on the slide. And then if I'm a pathologist myself and I use that tool, it's still on me to make sure that no mistakes were made. Like, no, that's actually causing more stress for me. What I want instead, and I don't think anybody builds it yet, is build me a model that is good at one thing and one thing only. It looks at a slide and tells me if it's normal or not. If it's normal, I do not have to look at it. Human not in the loop. If it's normal, normal. Just send it away, automate the report writing, no pathology found, normal. And so, 50 to 60% of what a human pathologist reads tends to be normal scans or normal slides. That would take away half of my workload. That makes it like the CBC. Machine does it, I don't have to check it. That is the kind of thing we need to be looking for. And then in the same bucket is this productivity efficiency trap alert that I would flag for people. Just like in the in-basket example, we went in assuming it would be an efficiency gain, as in time saving. We didn't find it. If we think about it, it's actually a productivity drop. And just bear with me for a second. Now, I'm not saying we shouldn't do it, okay? But let's get back to that as to why. So productivity is basically how much output you get and how much input you put in. Now, previously, whatever inputs you put in, human time, software, blah, 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 now you're paying for this extra thing. So you have plus cost for this automated response technology. It's small cost, but there's a cost. Your output in terms of number of patients seen is constant. It's flat. So whenever you have same output but higher input, what happens to this ratio? It goes down. Simple math. And so the fallacy here is that we are using technology to remove grunt work and sort of bad debt that should not have been there in the first place. A physician should not have had to respond to messages at 8 or 9 p.m. to begin with. So we had some inefficiency. We take out the inefficiency. Well, you could say it's an efficiency gain, but it's a bit sketchy. And so the point here is that when we apply this productivity efficiency mindset, paying down technology debt is not a gain. And we keep making that mistake. And so that is something I wanted to flag, that as we adopt technology, we really have to ask, what are the metrics by which we're evaluating it? And do those metrics, usually productivity efficiency, line up with the original intent and goal of the technology? And often you'll find, particularly in case of Gen AI, that it will not line up. And you'll see these absurd results like, oh, efficiency remained flat because we're still seeing the exact same number of patients. Productivity went down because now we're putting in more resources. But all we've done is paid off technical debt, which results in a happier workforce, which is probably worth paying for, but is not going to result in increase in access or any of those kinds of things. All right. And so to close out, I want to bring up two things. Thing number one is this idea of Turing trap, which is by Eric Brynjolfsson at the Human AI Institute. So let's say here's a box of all the things that can be done. And here's a circle of things that humans know how to do. The Turing trap is we use AI to do things humans know how to do. Basically stay in the circle. Let's build AI to do what I already know how to do, respond to in-basket messages. Turing trap. What about using AI to do things we don't know how to do? For example, go through millions of patient timelines and answer what happened to patients like mine. There is no doctor who can remember 1 million patients, period. It's beyond human cognition. But a computer, no problem. So as you think about responsible applications of AI, ask yourself, are we just falling into the Turing trap and then just falling victim to the productivity efficiency gain mindset? Or are we using the technology to do something completely novel that we could not have otherwise imagined? Like imagine remember the example of using a model to just rule out cases and say normal, normal, normal. Human never has to look at it. And so all of this is then parked into our responsible AI lifecycle, which I alluded to a little bit. There's nothing public about it, but the concepts behind that you can find in our Raise Health Initiative website. And that is all about how do all of these things we talked about, the financial sustainability, the productivity efficiency, the ethics, the stakeholder analysis, the firm assessment, where are we in that science practice delivery? How does all of that sort of come together as a ritual inside of our organization to do things right? And that's the responsible AI lifecycle. So I will pause here. We're at 9:44. Time for questions. And yeah, that's our list of topics for today. All right, so I see a question. Can we chain classical ML plus LLM to get combined cognitive load and performance wins? Absolutely. Yes, try it out. All right, a big reason for having human in the loop is regulatory clearance. Yes, it is definitely a shortcut and a cop-out. How do we go from state-of-the-art 100% human to completely independent one jump? Could you please comment on that? So that is where, remember that science, practice, delivery? I think we need to focus on that science of that. Uh, we're rushing to deploy things into practice and hoping for delivery gains where we have not yet done the basic scientific work necessary. That how do we go for complete independence? So the phrase we often use is human AI teaming. We have not studied human AI teaming. Jonathan Chen in my department studies that a little bit in one of the papers they had out recently. It showed that the unaided AI and the unaided human were better than the AI plus human. So human in the loop or AI in the loop was actually worse. And so I think we need to spend some implementation science or delivery science hours on figuring this out before jumping to implementation. All right, next one. How are timeline embeddings different from the LLMs to which the time of each event was provided? So conceptually, the embedding you obtain is very similar to what you get from BERT or Word2Vec or so on. It's the pre-training objective that is different. So most language models do not yet train for how many words will elapse till I see the word San Francisco. Like the inductive thing they look for is different. You could pretend training with the next token and shove in an extra time token. And I think we've done is some of my students, Michael Warno and Ethan Steinberg, have done that experiment. And just shoving in the time token versus training with an explicit time to event objective, I think training with time to event objective still wins. All right, last one, or sorry, next one. In light of the recent discussions about the role of AI in healthcare at a conference I attended, do you believe it is timely to advocate for the California Board of Nursing and similar licensing agencies to produce legislation akin to Oregon's House Bill 2748, which prohibits non-human entities from using the title RN or other professional titles? There's a similar measure, California AB 489. Do you think such measures are urgently necessary, and are you observing other professional organizations advocating for this? So, great question. I do not track this stuff. The short answer is yes, we should not rush to assign labels of degrees to these things. Going back to a previous question we had, but we haven't even figured out how to do human AI teaming. And if we don't know how this team is going to work, how do we start assigning roles up front? I think it would be a little bit premature to certify, AI models as nurses or doctors or what have you. Next one, where does prevention of disease come into play with the science practice delivery grid you proposed? How should we think about the patient data that is not currently in the healthcare system? So prevention, I would put it in science for sure. You could also think of it as preventive delivery. So in the delivery column, I would not put in the science, my mistake. Because if you're trying to improve efficiency of your delivery, and let's say you want to reduce the number of spine surgeries that need to be done, having a preventive musculoskeletal physiotherapy program could do that. So I would put it in the delivery aspect. And then data that is not currently collected, that's a tough one. You're absolutely right. Most of the good data are outside. I'm hoping, and it is a hope, is that these care coordination systems find a way to sort of look into these dark spots where healthcare doesn't look. Because in the interest of delivery, we do have to look into those non-healthcare data in order to figure out what works and what doesn't. All right, next one. What exposures do you have to AI and LLMs being used for the patient experience and not the physician experience? Is this the next wave of research or has it started? I love that question. And I tease my physician friends all the time that we're building toys for ourselves, which is, I think, a slightly poke way of saying that. There are a few LLMs that are patient facing. I do not study that for a living. I don't think it is that much research happening there. I'll name two individuals here, Akshay Chaudhary and Roxana Daneshju, who are studying the use of patient-facing language models. and figuring out what are the guardrails that we need to put in terms of what they do and not do. On the commercial side, I just heard of a company called Lumeris, which rolled out a patient-facing language model. They call it Tom. So I think the next wave has started for sure. Is it as big? Probably not yet, but it is definitely an area to be looking at. Okay. Shouldn't we carefully scrutinize the data before feeding it into the AI model, ensuring it aligns with the training distribution and considering factors like ethnicity, scanner type, other potential biases? Yes. Or has the AI been trained in a way that it performs well regardless of these factors? Nope. Data hygiene, data quality matter a lot. AI will inevitably generate predictions ranging from highly accurate to completely random, and such unreliable output should not influence radiologists' clinical decisions. Therefore, we may probably need a human in the loop. So the last one I would disagree with. I think we should only use AI for things where we don't need a human in the loop and take work away from the physician. Because otherwise, okay, if you're doing the science side, if you're trying to figure out what's the right human AI teaming and all that, absolutely, you put a human in the loop. But let's not pretend that that is the right delivery setup. That's the point that I'm trying to make. Do you foresee AI governance being automated? If so, how? That's a tough one. I haven't thought of that one. I don't foresee governance being automated. Is there a role for AI agents can play in automating AI governance? I'm gonna say no. I mean, they can play a role, but I would say I wouldn't want them to because in the end, I think the stakeholder analysis is a human process. Like we could probably use agents to run through a standard interview so that it can be done anytime at the convenience of the participant. So in that sense, yes, but I wouldn't grant decision-making autonomy or authority to the agents. All right. In the green button patients like mine study, it sounded like you're sort of running a small personalized retrospective clinical trial. Yes, small personalized retrospective observational study is what I would say. And if integrating into clinical care for decision making, how do you think about sample size? The service has a human interpreting the report and writing it. If it's a small sample size, too large error bars, we abstain from providing an answer. Um, More information is better. How do you think about statistical power? Again, based on the sample size. Um, and the power versus personalization trade-off, how do you draw that line? That's a brilliant question. It boils down to a judgment. Um, like at some point, if you go down to an N of one, it's a case report. Uh, if you have 1,000 patients, it's an observational study. Between 1 and 1,000, where do we land? It's a judgment call based on how rare the condition is. And most important, if you gave or did not give the information, would there be a net reclassification of the decision? Uh, if there's no net reclassification likely to happen, I wouldn't worry too much about it. If there's a net reclassification likely to happen, we would run some additional tests in the form of stability of the analysis, do some methods tweaks to see if you still keep getting the same answer and things like that. How do you foresee future product developments, life cycle in healthcare with advancement in foundation models and synthetic data generation? I think I'm not a huge fan of synthetic data as in synthetic EHR data, but in terms of adapting models, take a foundation model and adapt it to your local institution. I think for instruction tuning or fine tuning or adaptation, sometimes also called post training, I think synthetic data will probably play a significant role. Okay. A challenge for us in the biomedical world is that we lack the sorts of multi-domain simulation environments and governing equations that define the physical world. Other industries seem well equipped with physical or in silico models, but health and disease and biology are chaotic. Most attempts to create digital asset reproductions of the human body are too incomplete, not satisfiable. Wouldn't advancing in silico solutions unlock the sort of experimentation that we could never practically accomplish in living subjects? 100%. That lands in the science column for sure. And are we resigned to studying living subjects' data with no opportunity to meaningful causal inference? No, I don't think so. I think there is a argument to be made. The thing that goes under the shorthand of digital twin, which by the way now has evolved to have two meanings, but building a representation of biology in silico is a worthy goal. Like I did my PhD work trying to build something like that, and that was 20 years ago. It'll probably take a long time. That doesn't mean we shouldn't try. But until we have that, we do have to study the living subjects data because for patients that need a decision tomorrow, we can't ask them to wait another 20 years. The FDA approved the first foundational model a few weeks ago from AI Doc. I see two general approaches: modality-specific foundation model, multimodality foundation model. How does one go about efficiently measuring the presumed benefits of these multimodality foundation models? Is that a burden on the user? Love the question. This is something that the community is struggling with. Basically, who checks, right? I've I've come to sort of think of it as an ecosystem play. So imagine driving, a car. Who makes sure that the car is safe? It's not the end user. We have a few federal agencies like the National Transportation Safety Board, EPA, Environmental Protection Agency with emission standards, FTC to have truth in advertising. We have independent bodies like JD Power Associates, Consumer Reports, Edmunds, KBB, and so on. You still go do a test drive. And then after the test drive, you do take the burden of maintaining it and annual checkups and schedule maintenance. We have roads and traffic lights and rules about how to drive, how not to drive, and police to enforce it. I think we need something similar like that. Because expecting the end user to always verify presumed benefits is about as sensible as saying if you buy a car, you have to do your own crash testing. Like you can't do that. um, so yes, it's a great question, something we struggle with. And the current response from the community has been a little bit weird, so to say. Like we're just creating networks after networks after networks instead of having a strategy to create an ecosystem. So great question, love it. Um, what do you think about AI models being used for regulatory reporting, especially the AI models learning regulatory reporting requirements? What is the receptibility of a survey or invest? I'm not sure I follow this question. Um, regulatory reporting. Yeah, not sure I follow. I'm not gonna attempt. Last question. How can student researchers access high quality data sets while navigating the legal and administrative challenges of hospital data, especially for building responsible AI projects? Uh, Fair question. If you're a Stanford student, you do want to come talk to people at the AIMI Center or the data science team that I lead, or literally just go to star.stanford.edu and click on self-service and read. And I'm not joking in the slightest. We are amongst the few places where any student researcher can get access to the entirety of the de-identified research data warehouse by going to that URL that I just said, reading, and signing the appropriate data privacy attestation. Outside, it's a little bit tough. We are releasing a few data sets. So the AIMI Center has released about 20-25 imaging data sets. There's a 3 or 4 EHR data sets that we coordinated with releasing as well. And so that's where I would point you to. But yeah, if you're here as a Stanford student, star.stanford.edu, self-service, and then read that entire web page. All right. I think we're right at time, about a minute to go. So I'm going to stop screen sharing. And thank you all for joining us in today's AIMI Grand Rounds. And to claim CME credit, please refer to the text code earlier, or you will get information about over email as well after the session. And thank you so much for being with us, and we look forward to seeing you next time.